afternoon. I'm Dr. Kelsick Hobson, medical internist, and today we are going to be talking about lupus. Lupus, the word lupus comes from the Latin word meaning wolf, and the reason that the disease got this name was because the person who first discovered it thought this skin lesions looked like a wolf or a wolf bite. So what is lupus? Lupus, the longer name, is called systemic lupus erythematosus. Erythematosus means redness. Lupus, as I said, was given the name because of the skin lesions that the doctor who discovered it found. So there are two types of lupus. There's a systemic meaning it occurs all over your body. So there are different body systems: the lung, the liver, the heart, the gastrointestinal tract, and lupus can affect any one of these systems. There's another type of lupus called limited lupus, also discoid lupus, and that one mainly just affects the skin. But today we are going to be talking about the more serious one, which is the systemic lupus erythematosus. Lupus is an autoimmune disease. Now, what does autoimmune mean? Autoimmune means that your body sees part of your body as being foreign, as being not part of your body, and so attacks that part of your body. So it treats it as though it is something like a virus or a bacteria that's invading, and it starts to make antibodies to that part of the body. And you've been hearing a lot of the word antibody since COVID came up. But antibodies are made as part of the body's normal defense system to fight off and kill invaders. But lupus is when there is an aberration, as you could say, of that whole system. So instead of fighting things that are foreign, it starts those cells, such as the lymphocytes, the plasma cells, start attacking your own body and making these antibodies. In the case of lupus, it starts making antibodies to the nucleus. Now, anybody who did biology would know that most cells have a nucleus. That is the center part of the body. That is the sort of the governing part, the part that leads, the part that decides in the body. So how we decide when a patient has lupus primarily is by checking for an antibody called an ANA, an anti-nuclear antibody. So that's an antibody to the nucleus of the cell. Now, because the whole body is made up of cells, every part of your body has cells in it, it means that any part of your body can get attacked and diseased in a lupus patient. But there are some parts that are more prone to be attacked. So what is the prevalence of the lupus? Prevalence meaning how many people in 100,000 would have lupus. Overall, it's around 25 per 100,000. However, among black patients of Afro-American or Afro-Caribbean, the rates are very, very high. In addition, Mexican Americans have a very high rate, and that is about 400 per 100,000. However, Africans do not have a very high rate, and we'll discuss why that is when we start to talk about what predisposes, what we think is the cause of lupus. So again, we talked about who gets lupus. Well, the other group who gets lupus more than others are women in their reproductive age. So that is from around 16 to 55. And we think that's because female hormones such as estrogen play a role in the development of lupus. Men also get lupus, children also get lupus. And when men and children get lupus, it tends to be more severe. As well as when black patients get lupus, it tends to be more severe than when white patients get lupus. We're not sure why that is the case. Now, we said that the age is mainly about 16 to 55, but about 20% of lupus patients are less than the age of 16, so children do get it, and about 15% are over the age of 55. So older patients also have the onset of lupus. But as I said, the main age group are women in their reproductive years. Okay, so we talked about the lupus being a disease that attacks the antibody. So when we look at lupus, we do tests not just for the whole nucleus, but we do tests for part of the nucleus, such as the DNA, so anti-double-stranded DNA, anti-SM, anti-other parts. And when we test those and we find those positives, sometimes we can distinguish lupus from other type of autoimmune diseases. Okay, so there are subsets of diseases. Now, we talked about the age group, and in terms of how lupus presents, lupus usually presents with flares. That's when it gets worse, and remissions. That's when it gets better. Some patients, about 25%, have a very mild disease. About 25% have a very severe disease, and the other 50% have an in-between disease. Once you have lupus, you never get rid of it. All right? It might subside, but there's nothing called a cure for lupus. It might subside, it might go into remission, it might become milder, but you will always have the tendency, if you don't do the right thing, to have a flare. There's not a cure. However, some patients, as I say, have flares. Most patients have flares and remissions. So some patients have very few flares. However, we're going to discuss how lupus affects the body, and we said it could infect any organ system. In any individual patient, let's say it affected their kidneys, then when they have the flare, usually it's the kidney will again flare up. Let's say it affected initially their joints, then when they have the flare, it will be the joints that flare up. So generally, we can't say all patients are the same. Each patient is different. Each patient may have different organs that are affected. Again, we were talking about what predisposes a patient to lupus. Well, we know it's partly genetic, partly the genes. And why do we know that? Because we know if we have identical twins, there's up to a 50% chance that both of them will go on to develop lupus. We also know that if a mother has lupus and you test the baby or the child, as they grow up, about 25% will also carry the antibodies, although not all of them may go on to develop it. We also know that siblings of a lupus patient has about a 27 to 29 times greater chance of getting lupus than somebody who did not have a sister or a sibling with lupus. And we know that first-degree relatives also have an increased chance, about 17 times the risk of somebody who did not have lupus, have a relative with lupus. All right. What else causes lupus and makes it flare? Well, we know it has something to do with the sun. And we're not sure why, but we know that the sun damages skin, and skin is an important part of the disease with lupus. So we have to tell, it's called, lupus patients are what you call photosensitive. So the sun can make their disease flare up, and that's why we have to tell lupus patients, wear sunscreens, stay out of the sun, put on your long sleeves. Stress can make the disease flare up. We also think about other things that can make the disease flare up, and we know that about 10% of lupus patients will have it triggered by taking a drug. And there are specific drugs, we know the list, that can do this. One of them being a drug called hydralazine, which used to be used for which is still used for blood pressure control. So we're not sure if it is that that patient had the genes for it and the hydralazine triggered it, or the hydralazine actually caused it, the drugs actually caused it. We think maybe it's more of the latter, because drug-induced lupus is somewhat different to patients who get it genetically. Okay, then we would talk, there are other things that we have realized, and we wondered, as I said, why is it that Africans in Africa have such a lower incidence of lupus? In fact, it's not common at all, whereas it is so common in Afro-Caribbean people, in Afro-Americans. And one of the theories is that we know that patients who have malaria have a much lower risk of getting lupus, whereas patients who were ever infected by something called EBV, which is what causes infectious mono, and which is not common in Africa but common in Western societies, they have a bigger risk of getting lupus. There's also a theory that maybe it was because of genetic mixing. So the Africans who came over, most mixed. But we can find it in very dark patients who don't seem to have mixtures in our society. So we don't know if it's chemicals, we don't know if it's the food. Again, we know some things, we know it's genetic, we know it's photosensitive, we know it's drug-induced, but we aren't 100% sure as to what exactly causes lupus. So what are the symptoms of lupus? Well, a lot of patients go undiagnosed. There are many patients running around who are not diagnosed with lupus because some of the symptoms are so, what we call non-specific. So things like fever, just feeling always tired, hair loss, joint pains, headaches, fatigue. They may be the only symptoms that some patients have, and some may only have those symptoms when it first starts. The other thing with lupus is that sometimes it takes years to manifest itself. So initially it comes on very mildly with just these symptoms of real fatigue, headaches, not fogginess, not able to concentrate, and you don't know why this is happening, and then many years later something may flare up. So very often it takes a very astute doctor to think about testing for lupus. And one may find initially, sometimes, even when you test and suspect it, you're not going to get the blood test positive. All right? Might take a while for it to become positive. So some of the other signs are, and we'll go through them. I'm going to first go through the ones that we use to diagnose lupus, and then we'll go through some of the other organ systems that can be affected. So when we're trying to diagnose lupus, we look for rashes, and the characteristic rash is what we call a malar rash. So it is a rash that looks like a butterfly on the face, and I'm just going to pull it up and pass it around so that our audience could take a look at it. It's called a malar rash or a butterfly rash. Okay. So I'm going to show it on a dark person, what it looks like. and it will affect the cheeks or the malar area, but it will not affect this fold, the nasolabial fold, and that's how we know it's lupus. It never affects this fold. It stops there. All right? And there's another type of rash called a discoid rash. It's more of a scarring rash, and I'll pass that around afterwards. That's typical for lupus. One of the other criteria, as I said, was photosensitivity, the breaking out of this rash when the patient goes into the sun. Okay? The other diagnostic feature are mouth ulcers. Again, these are all fairly non-specific. Sorry, not non-specific. The rash is specific to lupus and characteristic of lupus, but oral ulcers can come with other diseases. And then we have the systems that are affected. So some of the systems are the joints. So you can get joint pain, all right? And characteristically, this joint pain is different to rheumatoid arthritis in that it generally doesn't make the joint deformed. The joint just gets swollen and warm and hurts, but it doesn't make your joints all deformed in general with lupus. And then we have some of the most common and most diagnostic and the most severe organ to be affected is the kidney. And usually when you have kidney disease, that's a severe form of the disease. However, while we find that 50% of patients will have signs clinically, in other words, we can diagnose it, if we were to biopsy all lupus patients or take a piece of their kidney, we would find that 75% had kidney involvement on the test, but it wasn't showing up as disease. So the kidney, as I said, is the one organ that is the most severe and the most commonly affected. The other organ that is very often affected, and we include this in the diagnosis, is the brain. And what the brain shows is patients may just be depressed. Okay, lupus patients may have depression because of their disease, because of how the disease affects their brain, or they may have depression because they can't cope with the disease. So it's sometimes difficult to tell which. Lupus patients can also have seizures, and they can also have psychosis, which is where the patient is paranoid. He thinks he's seeing things, all right? People are doing things to him. So any psychotic or depressed patient really should, in our society, be checked for lupus. Have the blood test. Okay? So we talked about the brain, we talked about the lungs, we talked about the kidneys. Lupus can also affect the blood. Now the blood has several different kinds of blood cells. It has white cells, red cells, and platelets. Platelets prevent clotting. Lupus can affect all of those and make them low. So you can get anemia, you can get low white counts, you can get low platelet counts. And lupus also affects the vascular system in that it can create an antibody called antiphospholipid antibody that predisposes those patients to developing clots. So sometimes the first time that you diagnose a patient will be in somebody who develops a clot, and you have no reason. We generally look for a secondary cause in a patient who develops a clot and he doesn't have any reason. So patient not fat, overweight, didn't do any travel, wasn't taking any sort of contraceptive. There are reasons why usually most patients didn't have no surgery, wasn't in bed, didn't get a fracture. All those reasons why a patient would get a clot doesn't exist. So in that case, and especially in that age group, 16 to 55 women, if we're astute as a doctor, would test that patient, especially if they had any other symptoms. All right, so we talked about some of the systems that we use when we are diagnosing lupus. But there are other systems that can be affected, such as the lungs. And one other thing that lupus does is that it affects the lining of organs. So it affects the lining of the lungs, the pleura. And in affecting the lungs, you get a symptom called pleuritis. So, and that is chest pain that's worse when you take a deep breath in. So it affects the lining of the lungs, it affects the lining of the heart, called pericarditis, and it affects the lining of the bowels, called peritonitis. So a patient could come in with severe abdominal pain and we think the patient has something going on and needs surgery, and in effect that patient might have had lupus affecting the peritoneum. Usually with all these, when you have that lining affected, you also get some fluid. So you'll get fluid outside the lungs, you'll get fluid outside the heart. So we mentioned, and that is again one of the diagnostic features of lupus. So we're talking about other organs affected. Lupus can affect any part of the heart. It can affect the lining, it can affect the muscles, so you could get something called a myocarditis. It can affect the valves, so you get something called endocarditis, which is particularly in this case, the name is Liebman-Sachs. You get little lesions, almost looking like they're bacteria. So lupus, it can affect the conduction system, so that you get irregular rhythms. It can affect the heart, any part of the heart. It can affect the lungs, as I said, and you can get clots in the lungs, you can get the lining of the lungs affected, you can cough up blood, you can get pneumonitis, just like as though you had pneumonia. It can affect the bowels. You can have any part of the bowels affected. It can affect the spleen can get enlarged. It can affect the liver, you can get something called autoimmune hepatitis. So those are mainly, and in addition to affecting the brain, it can affect your nerves. So you can get what's called funny sensations in your fingers and your hands, something called a neuropathy. So it's stinging sensations, burning sensations, numbness of your fingers and your hands. Okay, so I have someone here who is actually a patient. And so I'm going to ask her to talk to you about how lupus affected her, what were her symptoms, and how she has been coping with them. And then I will get back to you in terms of how we diagnose lupus and how we treat lupus.
A pleasant good afternoon to everyone. My name is Jessica Clavier. I'm a nurse by profession, and I'm also a lupus patient. I was diagnosed in 2017. I was 37 years old at the time when I was diagnosed. I actually was admitted for another condition, DVT. And while lying in the hospital and doctor did his assessment, he noticed the rash, the butterfly rash that Dr. Hobson would have mentioned in my face. And when he first told me, I said to him no. I said no several times, and he said okay, we'll do the test. And we actually did 2 tests, one locally and one was sent abroad, and both came back positive. I actually felt depressed for a good 2 or 3 days. I wasn't eating as I would normally, and because I was thinking all these things I've heard about lupus, I would have nursed lupus patients and I would have seen them at their worst. All those bad things just came to my mind, that this is what's going to happen to me. Anyhow, I would have spoken with my mom, and I still get a bit emotional thinking about those early days. And I would have spoken to my mom, and she actually gave me the strength to grasp hold of this diagnosis and be positive. Thank you. So even though being a nurse and I would have seen patients with this, it was very difficult for me to accept, because I always see myself as a strong person. And so having such a diagnosis initially, honestly, I felt it was a death sentence. So again, speaking to my mom, we made a plan how we're going to go about approaching this for me and moving forward with life. So by day 3, I felt much better having spoken with my mom, and I knew right away I had to be proactive, because being in the health profession, I had to be an example for patients who would be in my position. Very sorry. Like I said, it's very emotional for me. Okay. So initially for me, honestly, I had no idea that this was happening with my body. Around 2015, I would have seen changes in my body, starting with my joints. I actually used to have severe pain. It took me some time to get out of bed at times. I just thought, honestly, it's because of my job. I would be on my feet all the time, why I was experiencing the pains in my legs. And so I would just shake it off, take medication, and just go about my day. So imagine this is 2 years prior being diagnosed. I would have had a surgery in 2016, I would have had surgery. And maybe about 5 months after my surgery, I realized my legs were swelling. No explanation. Again, I just brushed it off as, okay, I'm on my legs all day, so it comes from my job. One day, I was at work and I would have gone to work feeling normal, and when I left work, I realized there was this strange pain at the back of my left leg. I didn't think anything much of it. I actually went home. I realized the pain was getting worse, so I said I'll go to bed, because that's me. If something is wrong with me, I tend to go to sleep. I said by the time I wake up, everything will be okay. So I worked that day, and it was a Saturday. And when I woke up the Sunday morning, I realized the pain was still there. I actually couldn't apply any pressure to my leg. So I still went to work because I was scheduled to work, and I just limped around for my entire shift. I let the doctor look at me while I was at work, look at the leg. It was warm, so we opted to do the test to check for blood clots. Thank you. I actually did my shift and I went home, but then in the evening I got a call urging me to return to the hospital right away, because the test was positive and the levels were really high. So that was my admission for DVT when I was diagnosed with lupus. I went into the hospital for something else, and I was given the diagnosis. So that was my first symptoms. And then after I was diagnosed, I was reflecting on my entire body, because again, I would have been experiencing changes. I would have realized my hair started thinning about 2016 as well. But I just thought I was getting old, because as Dr. Hobson said, the symptoms, they are very non-specific. So for me, as a healthcare worker, I always brushed it off to something else. I was never thinking lupus. So I would have lost my hair, started putting in weaves and whatnot, so I could look like the normal Jessica everybody knows me to be. So fast forwarding some more, being diagnosed, I realized that my diet played a very major role as to whether or not I got flares. When I do get flares, my symptoms are mostly my joint pains, and I tend to have the oral sores in my mouth that doctor would have mentioned, I realized one of the key things was animal products. If I eat lots of meat, whether beef, chicken, pork, I definitely will have a flare. My legs will swell, I will have joint pains, I will have the oral sores in my mouth. So doctor suggested that I go strict vegan, which I actually did. It was very tough for me because I could very much remember my first Christmas. I was like, Christmas, no turkey, no ham. So it was very, very tough for me, and I did do without turkey and ham that Christmas. However, I would have gone an entire year, no meat, nothing from animal, and I would have felt stronger. As Dr. Hobson would have mentioned, fatigue is one of the signs and symptoms. I used to sleep a lot, and I just thought that I used to be tired from work. But if I don't get 12 hours rest, I don't feel rested. I have to sleep for like 12 hours or more to feel fully rested. Now, another thing for me in terms of diet, like I said, I went an entire year, no meat. I would have traveled to China 2018, and there I ate regularly, and I actually lost weight. I was eating meat because I had to eat what was available to me, and I realized I didn't gain any weight. Come back home to St. Kitts, I continued the regular diet, and I had a very terrible flare. I actually ended up being hospitalized, and I said to myself, Jessica, you really have to cut meat out of your diet. I say all of this to say that persons who are out there, it's very important to know your body, to pay attention to the changes, because sometimes you may think that the change is normal, and most times it's not normal. So it's very important to go to your doctor regularly and get your annual physical and your annual checkups, because certain things, again, you may think is normal, is actually your body telling you something is going wrong. How I'm coping, I always bring my mom, and I get emotional. She is my strength. She is very supportive. Anything that I need in terms of my disease condition, she is there. And I cry because at this age, I see myself as a person who should be taking care now of my parents. However, here's my mom still taking care of me. Sorry. It's very, very emotional for me, and for anybody who is diagnosed with lupus. I wish that we had a society or something actually was trying to create that where we could meet and talk, because going through this, if I didn't have my mom, I would have felt alone, honestly. Because even though I have the doctor is just there to tell you what to do to take care of yourself when you're home. But sometimes with lupus, you need somebody to talk about what you're going through. There was so much physical changes to my body. Anybody who knows me, I was fit, slim, trim. Being diagnosed with lupus, I exercise. I cannot tolerate it like once ago. I'm so sorry that I'm so tearful. I didn't even expect to be so tearful. Exercise, once ago, I basically was a gym rat. But now, I don't have the strength. When I'm finished working, all I want to do is just rest so I can get up and go back to work. So again, I wish we had a society where
we could meet and talk about what we're going through, and I think that would give us strength as persons in St. Kitts and Nevis who are trying to cope with lupus.
There is a society.
Okay.
There is a society.
Yeah.
It's just autoimmune, it's not lupus.
Okay.
All autoimmune diseases.
Yeah. But never mind my tears. I'm very happy I function normal. Again, if anybody see me on the road, they would have no idea that I battle with lupus on a daily basis. Even my patients, they would have no idea. And I don't get tearful when I speak to patients who are diagnosed, and I try to give them the strength that I do have. And I actually had the opportunity to meet with 2 females. They were very sad. I met them at their depressed state, and I saw one recently, and she's doing very well as well. And she said I was the one who gave her strength to see it positive. So again, it's not a death sentence, and it's very important to take care of your body and listen to what your body is saying to you. Thank you.
Okay, well, that was very moving, and we really thank Jessica for sharing her experience with, especially for patients out there who have the disease and feel like maybe they're going through it all alone. There is a society, and perhaps we could get a number that when this is broadcast can be put up. It's autoimmune disease. Most of the patients right now in it are patients with rheumatoid arthritis, but it's for anyone with autoimmune disease. Okay. So Jessica told us about all her symptoms, and all those symptoms are symptoms that would prompt us to do a lupus test, especially hair loss, all right, the fatigue, unexplained fatigue, as I said, many of those organs that are involved, the joint pains, the rashes. Anybody, I think anyone in St. Kitts who gets a clot and we can't explain it should be tested. And any woman of reproductive age should be tested. The other things that the mouth ulcers, the problems with the heart, especially in unexpected patients, young patients in that age group who you wouldn't expect problems with the heart. Patients, as I said, if you have funny sensations, when we talk about peripheral neuropathy, any peripheral neuropathy, I test for lupus. So patients who come in complaining of tingling of their fingers, their toes, or loss of sensation, numbness, that is what we call a peripheral neuropathy. So those patients I would test. The other patients we test for as well are patients who have carpal tunnel syndrome. That's a syndrome where your wrist, it gets affected. And some of these other conditions that if we examined and found, like the pleuritis, the pericarditis, the peritonitis, the inflammation of the lung linings, as well as when we see problems with abnormalities in their blood cells. So again, how would we diagnose lupus? Well, the main test we do is that test called an ANE, which is anti-nuclear antibody, because that is what shows up, because what lupus is your body attacking your nucleus. And so that antibody, and forming that antibody called an anti-nuclear antibody. After that, we would go on and do the double-stranded DNA, because those patients in particular are the ones who are going to get kidney disease. Most patients who have kidney disease will have that antibody positive. All right, not all patients who, as I said, it would be unusual to have the kidney disease and not have that antibody positive. But because you have that antibody positive doesn't mean that you have kidney disease. Okay, so there are other tests we would do as well. We do the test for the clotting, the antiphospholipid antibody. When we diagnose in a patient, we'll do that test. We'll test their urine as well to see if their urine has any protein. And we do tests for inflammation, what we call a SED rate or a CR rate, to see if that patient has signs of inflammation, especially in the patients who have the joint pains. So having done that test now, what are we going to do? Well, we are going to try to classify that patient. Now remember I said some patients will just start with one symptom or two symptoms, and we maybe think that that patient has lupus, but for all those diseases I told you and the blood test, the patient has to have 4 of those for us to say for sure they have lupus. If they have less than 4, they may have another kind of autoimmune disease, all right? Or they may have what we call undifferentiated connective tissue disease. That is a patient who maybe has some of the symptoms, but not enough to call them lupus, and maybe has a positive A&E, all right? Or maybe doesn't have the positive A&E as yet. So that type of patient we would just follow. Sometimes I've had patients who take like 4 or 5 years before we could figure out, before they have another symptom or flare or another organ involved, that will tell us, yes, this is probably going to be lupus. Then we have what is called an overlap syndrome. That is patients who maybe have 2 connective tissue diseases. So maybe both lupus and rheumatoid, or both lupus and something called Sjogren's. And then we have something called mixed connective tissue disease, where again, there are 4 different kinds of connective tissue disease, and some of these patients may have more than one of them. So the connective tissue diseases we are talking about are dermatomyositis, polymyositis, that's where the skin and muscles are affected. Scleroderma, that's mainly where the skin is affected. Lupus, as well as rheumatoid arthritis. All right, so those 4. Some patients have what we call mixed connective tissue. They have more than one of those. All right? Okay, so when we test for lupus, sometimes we don't get the A&E positive, but there's another test called an SSE, which may come up positive. And which of these come up positive can point us to which one of the subsets of the autoimmune disease. All those, the Sjogren's, the scleroderma, the rheumatoid, etc. Not rheumatoid, but the polymyositis, which one of them the patient has. So we do specific tests once we get that positive A&E. And then we look to treat. So what do we treat with? Well, the one drug that everybody benefits from in lupus is a drug called Plaquenil, the hydroxychloroquine, the one that the US president was touting as a cure for COVID, and as a result, a lot of lupus patients couldn't get it and so got worse. So if you've been hoarding Plaquenil, kindly return it. All lupus patients need it. They're all short of it. All right? But that is a drug that we put most lupus patients, first drug we put them on. And that really helps the joint pains, the rashes, the skin rashes, and helps to get the other symptoms better. The second drug a lot of patients go on, but we don't just use them for those non-specific things, not the joint pains, etc. When they have other organs affected, we would use something called a steroid, such as prednisone. And that really, really is like a lifesaver for a lot of patients. But it has a lot of side effects. So after we get them out of the acute, get their symptoms under control, we try to use something that is not as, doesn't have as many side effects long term. And some of them, I just will name them, you may not have heard of them, but there would be like methotrexate, there would be some cyclophosphamide or cytoxan and mycophenolate. And then there are some newer drugs which we call biologicals, who are very, very expensive, and we don't really have many people on them here. They usually have to go away to get put on those drugs. But all those first ones that we mentioned are all available in the Federation. And also a drug called Imuran, which is very available through the healthcare system. And again, if the disease is mild, we can use that to try and reduce the prednisone. So that's treatment. Huh? The Kelsick, that's probably the mycophenolate. The mycophenolate. All right, so on top of that, we also use lifestyle. As Jessica said, diet is extremely important. Eating a healthy diet. So all lupus, in fact, all autoimmune patients have to come off of red meat. We take them off red meat and we put them on a more Mediterranean diet, which is more plant-based foods, plant-based proteins, peas, nuts, beans, lots of fruits and vegetables. They have to get a lot of rest if they can, but we don't advise them to exercise when they are having a flare or when their joints are affected. But in between, they have to watch their weight, try to do whatever little bit of exercise, but as Jessica says, that's not always possible when you're not feeling well. But the diet. And if patients are not getting enough of their one nutrient that we want them to have a lot of is called omega-3, and they get that in like fish, fatty fish like salmon. All right, but if we think that patients are not getting enough omega-3, we put them on supplements of omega-3. We also put most lupus patients on vitamin D. The reason being, they can't go out in the sun, so they are not making enough vitamin D, because your body makes vitamin D when you go into the sun. So most lupus patients we will put on vitamin D as well. All right, and as I said, lupus patients we have to treat them as special patients, because not only do they have their disease, but they're on some of these medicines that can put them, for instance, all those drugs that I told you about, the prednisone, etc. The lupus patient has a system where the anti-inflammatory system is overactive. The system that should be looking out for invaders like bacteria and virus. So when we are treating them, we are suppressing their immune system, their inflammatory system. And in doing that, we are actually putting them at a bigger risk for getting infections. So we have to treat lupus patients as very special. We have to make sure they have all their vaccinations, that they get influenza, that they get pneumococcus, that they get all the infections vaccinated against, but they can't take live vaccines when they go on these drugs. Because when the patient comes in with fever, we won't know if it's the disease, lupus, or it might be an infection. So lupus patients have to watch their body and report everything to their doctors that they see different. Because it may be the medication, it may be the disease. These patients are very complicated, we have to pay a lot of attention to them, and we have to treat them as special. So what is the prognosis of lupus patients? Well, for those who have kidney disease, these are the ones who don't do very well, all right? And so in the initial years, the complications they would have would be related to the disease. And in the latter years, in addition to having complications from the disease, especially the kidney, there's also a higher risk of having heart attacks. So in latter years, because they have this overactive inflammatory system, it also affects their heart. So many patients, we have to watch their cholesterol and we have to treat it. And we have to treat them, as I said, as very special patients, because they have a higher risk of morbidity, which is disease, as well as mortality, which is death. And later on, most of the deaths are from the kidney and from the heart. Early on, it's from the disease itself. But as I said, 25% are mild. I would put Jessica in the mild because she doesn't have any major organ system involved. 25% are severe, and most of those are the ones who have kidneys disease, and 50% are in between. And we have remissions. I actually have some patients who go into remission and never get it back, although they say if you test their blood, it's always there. But I have a couple who have never gotten it back. So I know they said you're never cured. You always have to treat that patient as though that they still have lupus. Every time they come into you, you have to check them. But I have one or two who it just remitted after a while. So I think that is the end of our presentation. I hope you learned a lot. I hope that if you see this, you advise anybody you know with lupus. We're going to put up a number for them to contact the society. Notice it's all
KNA agency. I present this.
Thank you very much. Thank you very much to KNA.
And we really appreciated your topic that I selected, and it was expounded on very well. And I hope you people out in the community will know lupus has all sorts of ways of attacking. So whenever you feel it, try and catch the doctor's office, not A&E department. Okay. Dr. Hobson, any internalist, they're the ones who deal with those deep patients and problems. Please make your start by any internist. Doctor, thanks much for your
Thank you very much.
time that you devoted to us.
And to KNA, this is what lupus patients should be eating: healthy food.
I wanted to thank you. They leave me teary eyes. Sorry. Thank you. And thank you to KNA.